Hello, my name is Dr. Polyak, and today we will be speaking about vasoplegic syndrome after cardiac surgery. Thank you so much for the invitation to speak. What is it? When do we see it? In short, vasoplegic syndrome is persistent hypotension as a result of pathologic vasodilation in the setting of normal or increased cardiac index. The resultant capillary leak leads to third spacing and tissue hypoxia. It is most often seen in cardiac surgery, with increased complexity of surgery leading to higher rates. So surgery such as LVAD or transplantation results in rates of vasoplegic syndrome that approaches 50%. Sepsis, major trauma are other common causes. There are multiple other conditions that may mimic vasoplegic syndrome, such as cirrhosis, anaphylaxis, high spinal cord injury, pancreatitis, and adrenal insufficiency. We'll touch upon those a little bit later. We know that vasoplegic syndrome is a vasodilatory shock. A more exact definition is a mean arterial pressure of less than 65 with a cardiac index of greater than 2.2 and systemic vascular resistance less than 800. Additionally, the patient should require pressure support with at least 0.2 mics per kilo per minute of norepinephrine. If caring for this patient in the operating room, a systematic approach is helpful to narrow your differential. A quick glance at the surgical field to rule out an obvious issue such as compression or bleeding. Look at the monitor to see if there is hypoxia or another ventilatory problem, and at the vaporizer to rule out inappropriate anesthetic depth. Use TE to evaluate heart function, the position of the cannulae, and volume status. Don't forget about the RV, as RV failure is a common cause of hypotension. A closer look at the medications, such as nitroglycerin, milrinone, and protamine, and the last thing given. Calculate your cardiac output and systemic vascular resistance. The purpose of a systematic approach is to rule out other conditions that may contribute to the hypotension. Once you've eliminated common causes of hypotension, consider other etiologies of low SVR state. Narrowing the differential is often challenging, but can be narrowed based on circumstances. Anaphylaxis. Look for recent administration of a potential inciting agent. Look for supporting evidence such as bronchospasm and a rash. Did the patient recently receive a transfusion? In that case, consider a transfusion reaction. It may present similar to anaphylaxis, but may also have fever and dark urine. Sepsis may have concomitant fever and decreased PaO2 over FiO2 ratio, and likely a history of endocarditis or other infection. Adrenal crisis, while difficult to assess in an anesthetized patient, may have fever, hyponatremia, hyperkalemia, hypercalcemia, and hypoglycemia. The remaining factors listed here are more circumstantial depending on patient history. Once diagnosis of vasoplegic syndrome is established, management should address volume status and low systemic vascular resistance. If there's concomitant low cardiac output, consider anatropes and mechanical circulatory support. Manage anemia, cardiac and respiratory function to prevent end organ damage. Assess for other factors in the differential and treat appropriately, which may involve antihistamines and steroids. We mentioned the importance of adequate volume prior to proceeding with other treatment modalities. Determining volume status can unfortunately be a separate talk on its own. Start with a 20 to 30 ml per kilo bolus, and then proceed with one of the options to guide further resuscitation. Appropriateness may differ depending on the setting. In the ICU, passive leg raise mimics a bolus of 150 to 300 mLs. A greater than 10% increase in cardiac output indicates fluid responsiveness. You can follow lactate levels but that can depend on how quickly your laboratory can turn around the results. TE is an easy modality to use when available. Post-pressure variation, pulmonary wedge pressure, and one of the newer modalities is mini fluid challenge. It's an easy modality to utilize with limited resources. You give a 100 ml bolus over 60 seconds. A greater than 10% increase in stroke volume index indicates fluid responsiveness. Norepinephrine is frequently one of the first options chosen when blood pressure is low in the setting of vasoplegic syndrome. Norepinephrine affects alpha and beta 1 receptors. It increases SVR, restoring perfusion pressure. The typical dose is 0.02 to 2 mics per kilo per minute, but prior to reaching maximal doses, a second agent is often introduced. Some of the side effects to be aware of are arrhythmias, tissue malperfusion, pulmonary edema, and hyperglycemia. You have to be really careful in patients on MAOI or tricyclic antidepressants, as it may lead to severe hypertension. Another commonly used vasopressor is vasopressin. It's an endogenous hormone. Stimulation of V1 receptor causes vasoconstriction, whereas stimulation of the V2 receptor causes water reabsorption at the collecting ducts. It blocks potassium ATP channels, preventing hyperpolarization, and reduces nitric oxide synthesis. Although we didn't go over the pathophysiology of vasoplegic syndrome, potassium ATP channels and nitric oxide are significant causes of vasodilation. Typical doses are 0.02 to 0.1 units per minute, but most maintain a stable dose of around 0.04 rather than titrate this medication. Although vasopressin is typically introduced as a second agent, the Vanks trial and a few others brought into question whether it should be the first agent used. The Vanks trial is a randomized controlled trial comparing vasopressin and norepinephrine in 300 Brazilian patients with vasoplegia after cardiac surgery. It showed overall non-inferior outcomes, but the vasopressin group had less atrial fibrillation and acute renal failure. A criticism of this study was the high mortality rate of 15%. Many other trials and meta-analyses have examined the role of vasopressin in distributive shock. In sepsis, the VAST trial, which was a randomized controlled trial of 778 patients, showed no difference in outcomes, including mortality, with the addition of vasopressin. McIntyre did a meta-analysis of 23 trials with over 3,000 patients with distributive shock. In his trial, he showed decreased atrial fibrillation in patients treated with vasopressin. Finally, Zelis did a meta-analysis of 10 trials looking at primarily vasoplegic shock and found a trend towards shorter hospital stay, but the results were not statistically significant. Angiotensin II is the newly rediscovered non-catecholamine vasopressor. The typical dose is 5 to 40 nanograms per kilo per minute with a maximum of 80. Typically you start at 20 and increase by 15 every 5 minutes until blood pressure targets are achieved. After 3 hours, the maintenance maximum dose is 40 nanograms per kilo per minute. Use is primarily based on the Athos 3 trial, which showed improvement in blood pressure targets. This was a trial in 321 patients that were randomly assigned to either angiotensin II or placebo once norepinephrine reached 0.2 mics per kilo per minute. Unfortunately, 30% of the patients did not achieve their blood pressure targets at all. There was greater improvement in the sequential organ failure assessment at 48 hours in the angiotensin II group. There was no mortality change. On a post hoc analysis, low-dose angiotensin II led to survival benefit. The dose in that analysis was less than 25 nanograms per kilo per minute. There was also improved oxygenation in ARDS. The listed side effects such as thrombosis, tachycardia, thrombocytopenia, acidosis, and hyperglycemia were not seen in the Athos 3 trial. Colson performed an interesting feasibility trial. 60 patients received blinded, equipotent doses of either norepinephrine or angiotensin II with the goal of maintaining a mean arterial pressure of 70 up to 48 hours. The norepinephrine group had higher stroke, renal failure, and mechanical support. But because this trial was small, the results were not significant. There was also reduced length of stay. Again, the results were not significant. The bigger trial, Porthos trial, will look at 400 patients, norepinephrine versus angiotensin II, looking at length of stay, cardiovascular, renal, and blood pressure outcomes. The results of the trial are not out yet. C et al. Did an observational prospective study in the ICU. They looked at 120 patients with vasodilatory shock. 40 were treated with angiotensin II, and 80 were matched controls. They noted lower troponin levels in the angiotensin II group. The angiotensin II treated patients also had lower ICU mortality, but not 28 or 90-day mortality. Renal replacement therapy and AKI rates were similar, but patients with previous exposure to ACE inhibitors had lower creatinine overall. Until more conclusive results from randomized trials shed some light, a January 2025 editorial at JCVA came to the following expert consensus. Angiotensin II is a valid treatment option. It reduces catecholamine use, and you should consider it in patients in AKI or renal replacement therapy. It's attractive in patients with low ACE activity or on ACE inhibitors. In severe vasoplegic syndrome, vasopressors are often not enough to normalize blood pressure. Escalating doses of vasopressors leads to more complications. Several alternative therapies have been examined to reduce the need of for vasopressor support. One of the most studied adjuncts in the treatment of vasoplegic syndrome is methylene blue. It's usually used to treat methemoglobinemia and for lymphatic mapping. It inhibits nitric oxide synthetase and competes with nitric oxide for guanylate cyclase binding sites. It does not activate the enzyme, therefore it's a competitive inhibitor, thus reducing production of cyclic GMP and subsequent vasodilation. The typical dose is 1.5 to 2 milligrams per kilo bolus over 15 to 30 minutes. Sometimes it's followed by an infusion of about 0.5 milligram per kilo per hour for the subsequent 6 to 12 hours. Several studies have shown that it increases mean arterial pressure and lowers catecholamine requirement. Some studies have even shown decreased mortality, renal failure, and lactate levels. Some of the side effects to be aware of include seizures, headache, nausea, diarrhea, and phototoxicity. It also interferes with pulse oximetry with recovery after about 6 minutes. It's contraindicated in patients that are on serotonin inhibitors, such as SSRIs, SNRIs, or MAOIs. Serotonin syndrome is a deadly condition that can be precipitated by combining methylene blue with these medications. It can also lead to hemolytic anemia in patients with G6PD deficiency. Several studies looked at giving methylene blue early. McCaffrey, in a retrospective study of 118 patients, showed that early administration in the operating room versus ICU led to decreased mortality. The treated group had a mortality of 10% versus 29% for the control group. In the study by Ozel, methylene blue 2 milligrams per kilo or control were administered to 100 patients at high risk for vasoplegic syndrome. This was done in the ICU 1 hour prior to surgery. The treated group had 0% incidence of vasoplegia, versus 26% for the control group. Maslow did a study in 30 patients on ACE inhibitors, randomized to either methylene blue 3 mg per kilo or control at the start of cardiopulmonary bypass. This is prior to any vasoplegia. The methylene blue group had higher blood pressure, lower lactate, and needed less norepinephrine. It's common practice to start an infusion of methylene blue after the initial bolus. A retrospective cohort analysis by Holfelder from Cleveland Clinic looked at 44 patients. 33 patients received only the bolus of methylene blue without a subsequent infusion. There was no difference in hemodynamic response between the two groups. A recent meta-analysis by Pruna looked at 11 studies with 556 patients. The cohort was mixed between perioperative and critically ill patients with vasoplegic syndrome. The authors concluded that methylene blue led to lower mortality, ICU length of stay, and hospital stay. The analysis was underpowered, though. There's an upcoming trial called the MAGIC trial that's been ongoing since 2021. It's going to look at cardiac patients in New Zealand and Australia who meet criteria for vasoplegic syndrome and will receive 1.5 mg per kilo of methylene blue versus placebo. It should hopefully fully answer some of these questions. Another adjunct in the treatment of vasoplegic syndrome is hydroxycobalamin. It's used primarily in cyanide poisoning. It scavenges nitric oxide and inhibits the action of hydrogen sulfide. The typical dose for vasoplegic syndrome is 5 to 10 grams over 15 minutes. It's been shown to increase mean arterial pressure and reduce vasopressor requirements in several studies. In one of these studies, Seelhammer used an infusion of hydroxycobalamin, which led to prolonged improvement in mean arterial pressure. It's usually used as a second-line adjunct or if methylene blue is contraindicated. The side effects include headache, rash, and nausea. In patients that are on dialysis, it can interfere with dialysis because the ultrafiltrate may set off blood leak detection alarm. Many of the early studies are small and so should be interpreted with caution. Many found improved mean arterial pressure, but no improvement in mortality. More recently, investigators started comparing cyanokit to methylene blue and in combination. Furnish et al. Looked at 16 patients treated with methylene blue and 19 patients treated with hydroxycobalamin. Both medications increased mean arterial pressure within the first hour without other differences, including time-averaged norepinephrine use. Hirui performed a retrospective cohort analysis of 120 patients, of which 77 received hydroxycobalamin and the rest, 43, received methylene blue. Hydroxycobalamin led to greater reduction in vasopressor requirement. Finally, a meta-analysis by Bruckmeyer reaffirmed that both increased mean arterial pressure in a similar manner. Larger studies are needed, though. This small retrospective study of only 20 patients, with 6 receiving both hydroxycobalamin and methylene blue, looked at combining the two medications to see if there is improvement. They did see improved mean arterial pressure at 1 hour, but no further differences. Prospective studies are needed. Recently, one was planned by Dr. Lau at Dartmouth to compare methylene blue and hydroxycobalamin with planned administration on pump in high-risk patients. Unfortunately, the study was closed due to lack of funding. Another adjunct or combination of adjuncts that has been studied is HAT therapy. That's a combination of hydrocortisone, ascorbic acid, and thiamine. This diagram shows the multiple and overlapping effects of hydrocortisone, vitamin C, and thiamine. Let's look at each component individually. Hydrocortisone reduces inflammatory cytokines, inducible nitric oxide synthetase, and cyclohexogenase 2. It enhances the synthesis of catecholamines and receptor expression. Although several randomized clinical trials showed a reduction in vasopressor use, intubation and ICU stay, and sepsis, there was no effect on mortality. The major trials in cardiac surgery, the SIRS trial and the DEX trial, did not show a major difference in mortality or major outcomes studied. These are older trials. Some later trials of high-dose steroids saw an association with MI. This meta-analysis of over 18,000 patients looked at prophylactic hydrocortisone. Although these patients did not have established vasoplegic syndrome, the study found shorter time to extubation, ICU, and hospital stay, as well as lower risk of atrial fibrillation and acute kidney injury. Ascorbic acid, or vitamin C, is the second component of HAT therapy. It's a cofactor to several enzymes in the synthesis of catecholamines, and it also increases sensitivity of adrenal receptors. Wyrzewski looked at this in a series of 3 patients. He gave them 1,500 milligrams of ascorbic acid every 6 hours, which allowed for rapid weaning of vasopressors. However, subsequent randomized controlled trials by Yanase of 50 patients receiving the same dosing found no difference in resolution of vasoplegia. Several other randomized trials in septic shock, such as the LOVIT trial, showed increased risk of death, renal replacement therapy, and positive fluid balance. 1,500 milligrams is a huge dose of ascorbic acid. For perspective, a lemon contains about 35 milligrams of ascorbic acid. Thiamine is the third component of HAT therapy. It's a coenzyme for glucose metabolism and has anti-inflammatory effects. Donino randomized 88 ICU patients in septic shock to either receive 200 milligrams of thiamine or placebo. The treatment group had lower mortality at 30 days. A subsequent retrospective matched cohort of 123 patients confirmed the findings. These studies created some excitement for the use of thiamine in vasoplegia. However, larger studies did not bear out the previous outcomes. Petsakul did not find a difference in outcomes in septic shock patients treated with thiamine. Likewise, Lamivarotov did not see an effect in the APPLY trial, where high-risk cardiac patients received prophylactic thiamine. Unfortunately, the evidence for individual components of HAT therapy is mixed, and the same goes for all 3 together. While a retrospective study by Marek in 47 septic patients showed a reduction in vasopressor use, the most important studies performed thus far, such as the Victus and Vitamins trials, do not show a benefit in septic patients. Busey described a great approach to help choose a path when treating vasoplegic syndrome. Start with vasopressors, methylene blue if there is not a contraindication, then choose hydroxycobalamin or angiotensin II depending on risk profile and availability. Outcomes with vasoplegic syndrome are variable depending on etiology, but most studies show that development of the syndrome is associated with mortality and multi-organ failure. Future trials should further elucidate the role of current therapeutic agents and the timing of treatment. Glibenclamide, it's an experimental agent that was found to be effective in restoring SVR, has some potential, but needs further study. Vasoplegic syndrome is common in cardiac surgery and in critically ill patients. Once diagnosis is established, consider fluid challenge followed by vasopressin as first-line agent with addition of norepinephrine. Consider early methylene blue if there is no contraindication. Hydroxycobalamin and angiotensin II are useful if additional blood pressure support is needed. I welcome your questions.